I invite Dr. Manju Pillai for her presentation on challenging angle closure disease presentations.
So, good evening, everyone. So, have outlined my talk as basics of an angle closure and primary disease, secondary disease spectrum, and some clinical scenarios with some case presentations. So, why should we bother about an angle closure? Because POSAG is more than PACG, and PACG happens in 25% of all glaucoma worldwide, but blindness from PACG is 50%. So, the risk for blindness is 3 times more with PACG than POAG. So why is it difficult to pick up angle closure? Is because in a lighted room, the angles are open, and in a dim light, the pupils dilate, the angle crowding occurs. So there is an article on primary angle closure glaucoma on what we know and what we don't know. So there is some part of genetics that is involved, and there is a small cornea, shallow AC and short axial length, and small anterior chamber with greater iris curve and a larger iris volume. There could be an anatomical crowding, thicker peripheral iris, plateau iris, and anteriorly rotated ciliary processes, big lens wall, thick lens, and anterior lens position. And according to the age, living habit, mood, weather, and others, they can have a narrow ankles, which can lead on later to an angle closure glaucoma. uveal expansion can also close a pupillary block or a non-pupillary block. And I suggest American Academy of Ophthalmology Preferred Practice Practice, where Shweta has described about ITC. So in PAC, more than 180 degree ITC is present, the other two are absent. In primary angle closure, more than 180 degree ITC and elevated IOP or PAS is present, and primary angle closure glaucoma, even these changes are present. So in the disease progression, angle closure glaucoma, if the laser prior is a treatment in 22%, in 5 years' time, they develop to primary angle closure. In 28% or 28.5% in 5 years, they change to angle closure glaucoma. So we need to do periodically gonioscopy in all these suspects to make sure they have not progressed to angle closure and angle closure glaucoma. So in the laser peripheral iridotomy in primary angle closure, most PACS won't require further treatment. PAC, acute primary angle closure, and PACG eyes require further treatment to lower IOP. So why is PA not curative in all patients? If there is a pupillary block, if there is a plateau iris configuration, if there is a peripheral iris crowding, or if there is a high lens vault. So rich anatomic levels of angle closure, which Meena has described, the levels are iris and pupil, it can cause a pupillary block. At the ciliary body level, it's due to plateau iris. In the lens, it's due to phacomorphic glaucoma, and retrorental, it's malignant glaucoma. In East Asia, mixed mechanism angle closure is believed to be especially prevalent. WGA consensus for a prime prophylactic laser iridotomy is APAC, that's acute primary angle closure, and its fellow eye with PAC or PACG. Those who require a frequent pupillary dilatation, inadequate medical access, and symptomatic PACS. There are some clinical scenarios that I would like to explain to you. That is with pupillary block, that is in sequential pupillae, phacomorphic, aphakic or pseudophakic, and silicon oil induced. Without pupillary block, if there is an anterior pulling mechanism or a posterior pushing mechanism. So in a pre and post PI, this case is an iris Bombay due to uveitis post cataract surgery. It was relieved by a laser PI. Note that the laser PI was patent and deep anterior chamber is there after a PI. Pupillary block by fibrin membrane, that is post-operative day 50 after an uneventful SICS. All shallow AC post cataract surgery is not malignant glaucoma. You can see the deep PC in this eye. And UBM helps in picking up the cause, and fibrin membrane is covering the pupillary margin. So you can do a YAC PI, and if it's not getting resolved, you can even do a fibrin membrane lysis, and after 3 days, AC deepens centrally and intense steroids, and after 3 days, AC deepens well, and PI is small, but it's patent. Sometimes PI may not be curative in cases like this where there is a 360-degree Sinecave with flat AC as in a chronic uveitis, where we have to go in for alternative surgical procedures, mostly a surgical PA trabeculectomy, or after a B scan, once a uveitis settles down, we have to go in for a GDD. In lens-induced angle closure glaucoma, when there is ischemic cornea with intermittent cataract and high intraocular pressure, we have to always look for the other eye angles also, and the lens removal is the only treatment. Microspirophakia and secondary angle closure, you should note that there is a weak and abnormally elongated zonules in the microspirophakia. These enlarge anterior lens movement, leading to recurrent attacks of secondary angle closure, and we have to remove this cataract. And young male with high myopia presented acutely with high IOP and shallow AC, you note that there is a small lens in the uveum. There is another one entity that we come across, that is nanophthalmos. Post cataract surgery in both the eyes, AC even looks shallow even after a cataract surgery, and you can see an iris chafing because of the difficulty that we had in placing the lens. And this is the axial length to show that it was a clear-cut case of nanophthalmos. In pseudophakic glaucomas, IOL position can cause an angle closure. That is IOL in the sulcus with a secondary angle closure. The case like scenario was recurrent hyphema after phaco. UBM clinched the diagnosis that the patient had recurrent hyphema is because the single piece lens was placed in the sulcus. You should never put a single piece foldable IOL in the sulcus. So one haptic in the sulcus and UBM helped in picking up the cause. Another one entity that we come across all the time is a silicone oil induced pupillary block. You can see that the PC is very deep and iris will be steepened like this, and it will have a bend, and silicone oil would have filled the whole anterior chamber. The removal of the silicone oil bubble after PI, and the silicone oil bubble gets relieved to the posterior chamber, pupillary block is relieved and the bubble gets retracted. There are some cases where you don't have to do ACPI, and one is the ICE syndrome, where anatomy of the angle structures are like this, but clinical picture shows an entity that it's an ICE syndrome. And the neovascular glaucoma, where you can look very carefully. If there is a florid NVI, then you don't have to do a ACPI, you have to do alternate treatment along with Avastin or any other retinal pathology. And due to some other changed lenses or any other anterior chamber lens or something else, if they do somewhere outside and bring it, they get a malignant glaucoma, that is IOP is 34, corneal edema, flat AC and a patent iris. So 3 days after atropine, the IOP goes down to 12, clear cornea, AC is deep, and the fundus shows a decompression retinopathy. The trigger was an intraop hypertony. So you should see that the entire lens is shifted up. If the IOAC is not coming down with all these steroids and atropine, then we have to go ahead with a vitrectomy in these type of cases. So conclusion is, angle closure is a puzzle that has to be solved meticulously using all the available investigative modalities, not only gonioscopy. Only combined mechanisms of angle closure can happen often, and treatment can vary from LPI to complex glaucoma drainage device implants. Thank you.